for you.
Hello ladies and gentlemen and esteemed colleagues and the new Shockwave family who I've all met here by attending my first conference, and I'm delighted and honoured to be in a position to speak here today, so thank you very much for that. As I say, I come from the UK, and then knowing that I came from the UK and also that I was a physiotherapist, they still allowed me to attend, so we're very happy about that. So, my name is Paul Hobrough, I'm a physio, I'm an exercise physiologist, qualified to lecture, and I've written a book or two, which I'm very proud to say became #1 selling in the UK, all about running. What I'm here to talk to you about today is about OA knee, and particularly because when we get patients coming into a clinical setting such as mine, as a private practice, they're perhaps too young to have surgery, they perhaps do not want to have surgery, which is a common growing consensus in the patients I see these days. And so what do? They attend to a physio, and we have to come up with something reasonable within the clinic to do for them. I must say that I do teach for both Storts and DJO, so if there's any conflict then it's because I teach for them, but I do not sell machines. I literally teach. And I spent a large part of my youth travelling around the world as a kayak paddler, and I have 2 clinics which are Shockwave specialists in the UK, both in Hexham where I live and Harley Street. So there's some science that brought me to be here today, and it's interesting to look at some of the science and the fact that my colleagues who already spoke here this afternoon have brought up the same papers. And that is that it's been shown that shockwave therapy is effective in reducing pain and improving knee function. But the critical point in this study here was that they felt further pilot studies were needed, and so I decided to rise to that challenge. There's also been lots of information looking at animals, particularly in rabbits, where it looks like shockwave reduces the progression of knee osteoarthritis, possibly through reducing nitric oxide. And the chondroprotective effects that we've heard about already this afternoon, I think are important, and I think it's worth considering that whilst this is happening in rats, it may also well be happening in humans as well. So there's a couple of human studies before I present my own findings. So we've got an RCT of 120 people, and shockwave treatment showed to improve range of movement, muscle power and stability. There's also osteoarthritis of the knee in 70 people. It reduced pain in terms of the VAS score from 7.6 down to 3.8 in just 12 weeks. Now if you put that into consideration of people walking into your clinic as something you can offer them as an opportunity other than hobbling around the streets and wondering what they might do with their knee other than surgery, this becomes a very, very viable option. So we're going to hear now from 2 of my patients. These videos were taken just last month in 2019, and as they'll both tell you, they were in for their last session of 6 shockwave sessions, and I use a combined method of both radial and focus shockwave. And this is using the Chattanooga range and also the Storts range. So here's one of my patients, bilateral osteoarthritis of the knee, quite severe, which has a fixed flexion deformity.
I'm about to have my 6th section on shockwave therapy. Previous to having it, I couldn't walk very far without having to stop and rest. I'm now able to walk quite significant distances, and I don't have to rest, so my walking is definitely improved. And I'm now able to go downstairs correctly, whereas before I had to do one at a time, just leading left.
Trying to get it loud. So as you can see, we've got an extremely happy patient who can now go up and down stairs in the correct way. She's a head teacher at a school. It's heavily embarrassing for her to be walking upstairs one at a time, still relatively young, and this really restored her ability to go for a walk and to feel confident with her walking. The second patient, slightly older gentleman with bilateral knee pain. We're going to look in a little bit more detail on this chap here.
This is my 6th treatment today, and there's been about a 70% improvement in my knees. I have no pain at all when I'm walking on level ground, slight pain on hills and stairs, but absolutely perfect on level ground. I'm very impressed.
So again, we have another very happy patient. So look at this purely clinically. My colleagues before now looked at the science, looked at everything that sort of leads up to the point when you're in the sort of coalface of working with these patients. What do we offer them instead of perhaps surgery? And here we have just 2 examples of many that I could have chosen in my clinic. I would treat 14 patients a day, and 10 of those every day will have shockwave therapy. And bear in mind, this is a private clinic, so these people pay for their treatment, and shockwave dramatically increases the cost of their treatment. But it's the way in which you position it to them, this might potentially give them a significant improvement in their quality of life. So this particular gentleman, I got full consent for both, obviously. We have x-rays that confirm severe OA. He couldn't sleep at night, he couldn't play golf, he couldn't manage stairs well, he couldn't play golf again apparently, he couldn't walk very far. His range of movement, if you can remember these, 135 degrees of knee flexion, and he had a fixed flexion deformity, meant he was 5 degrees off of having a completely straight leg. He was in pain all the time, minimum of 4 out of 10, up to a normal sort of 7 out of 10. Now my protocol is we do 6 sessions, so once a week over 6 weeks. We do between 5,000 and 6,000 pulses. I use radial shockwave therapy on the quadricep muscles, and then we do the medial tibial joint line, or the tibial plateau. We do medial and lateral keyholes to the knee, and I do some to the lateral joint line with focus shockwave. And what's important to know is I do this with standoff number 2, and also with no standoff, to get patient feedback all the time about where they're feeling their shockwave. So I'm always looking and asking the patient where their pain level is. So I'm constantly getting feedback, and I treat very much to the patient's thought process on how it's feeling to them. So I'm constantly adjusting the amount of pressure that I'm putting through, and because of the type of devices I do, the frequency changes automatically. I also use without the standoff, as I just said, and I get feedback from the patient as to where they're feeling the treatment. And in all cases, they feel it's much more in the central part of the knee, whereas with the standoff too, they feel it much more towards the either medial or lateral borders of the knee. Constantly getting feedback from the patient. They direct how the treatment goes in many cases. And then this is the patient after his 6th treatment of shockwave.
It's all done on your say-so.
And we see a significant improvement on the baseline measurements, and he has hyperextension now. This is the gentleman that said he was 70% improved, and clinically we can see a reason for that. I'm also here to present on my final case study because I have a vested interest, which is my own knee. And some years ago, I had ACL surgery in 2004, and then I went back for surgery because this wasn't working very well for me, and I had some cyst removal, and also they took the metalwork away. I got another MRI in 2010, which confirmed moderate osteoarthritis, and I've had subsequent night pains and loss of flexion, and I would walk with a limp. I got an MRI scan again in 2015, which confirmed advanced OA. In fact, my orthopaedic consultant told me I had the knee of an 85-year-old, and yet I was only 44 years old at the time, so I was very depressed. In 2016, I started using radial pulse wave, because that was the first machine I got, and my symptoms went very, very quickly, and I felt like I had my life and my knee back. I then got a focus shockwave device in 2018, and I started using that device also, and that's where I started a combined approach to shockwave therapy, and this is where I felt the very, very best results. And I'm a huge believer that focus shockwave on knee OA has significantly greater results, certainly in my own knee, than using radial pulse wave alone. So the protocol I've used for myself, very similar. I do 6 sessions over 6 weeks. I allow 90 days for synthesis, and then I do a combined shockwave treatment again, another 6 sessions. And then once I've stimulated what I believe is happening within my knee, I then do it 6 monthly intervals thereafter, and I've continued that for the last 4 years, and I'm happy to say that I'm symptom-free, and I'm a very, very happy patient indeed. These are the MRI scans of my own knee. I had to go and get one done at my own cost ahead of coming to present here, and you'll see that one on the far right of your screen. And the report comes back saying there's mild progression over the 4 years. I think we can all agree that there is some fairly horrible looking knee on both sides, to be fair, but this is what I'm dealing with. There's reduced joint space, increased chondropathy, and there's increased size of osteophytes. But as I tell you, I'm symptom free. I have no pain whatsoever, and I put this 100% down to my use of shockwave therapy. So I'm very, very happy indeed. It won't let me advance to my last slide, which is to say thank you to you all. It's been a real pleasure, and I look forward to any questions on this study. So thank you very much.
Thank you, Bob. So I invite the speakers to come up for a round table and for a number of questions in the discussion now. We need the microphones now.